I have a quick question, Ms. D, about one of our reading assignments for, I think, week 12 was chapter 21. And it has a lot of, I guess, formulas for like, you know, calculus, degrees, and everything. Do you want us to learn each of them for the exam? Okay, thank you. It was a lot.
No, and I'll have, I think, anyway, yeah, I'll work that out. This should be an easier exam, I'm hoping. Number 6 will be an easier exam because like this chapter, Instruments and Principles of Instrumentation, guess what? You've had it all before. This is all a review. You know, the handle, the shank, the this and the that. There's going to be a little bit of new information, but not a whole lot. So I'm hoping that you can kind of take a breath from the last exam. Any other questions before we get started? Okay, feel free to interrupt me if needed. I'm going to take my lovely video off because you don't need to see me. And if, let me see, Jody, I'm going to put you in charge of the chat box because I'm going to minimize that. If somebody has a question, Jody, could you interrupt me, please?
Sure.
Thank you. All right, we're going to go over chapter 37 today, which is Instruments and Principles of Instrumentation. And as I said, this is going to be a review for everything that we've had so far. So let's just dive in. We're going to have an overview of periodontal instruments. Now we've gone over your assessment instruments, and what color in your kit are your assessment instruments?
Pink.
Pink.
They're the pink, right. And then the removal instruments are of various different colors. We've got the green for your supragingival scalars, the yellow with added color, yellow and orange, yellow and red. Those are your universal curettes, and then your gray situations for your area specific. So we hopefully, when you've got both your cassette open, you'll be able to zero in on where you need to start grabbing without having to look at all of them blindly, because they all do tend to look alike. So you need to determine what that instrument is, not only by the number and the name that's on the handle, but by the instrument design itself, because you're going to be faced with, at different offices, looking at instruments that you have never seen before. And if you know that the face of the blade is perpendicular to the terminal shank, you automatically will know that that is a universal scalar or curette. So let's go into just a little bit more. Okay, the handle, do you want it light or heavy? For the weight of the handle?
Light.
Light. Do you want it thick or thin?
Thin.
Thick.
Thick. Okay, you don't need it real big, but you want it thicker. Thicker is better than thinner. Texture, do you want it smooth or do you want it textured?
Texture.
Textured, exactly. And then you're going to be looking at the shape of the shank. Is it a thin shank like an Explorer, thin and flexible, or is it really thick? And that would be for your heavier deposit. The length of it will determine, is it anterior or posterior, as well as is it an after 5 for deeper pockets or not? And then the rigidity, is it for light, moderate, or heavy calculus? So the parts of an instrument, okay, we've got the handle. Do you remember what this texturing is called?
Knurling.
Knurling, very good. That I have seen on board questions. So just remember that it's knurling, all right? You've got your functional shank, which is attached to the blade, and then you have your lower shank. And what is the difference between the functional and the lower shank? What can anybody explain the difference?
Does it have something to do with the lower shanks, whether it's parallel or the angle against the tooth?
Exactly. That's your visual cue. The functional shank is the entire shank, and that's got all the bends in it to allow you access to where you need to go. And the lower shank helps adapt that blade, the working end, underneath the tissue, so you have a visual cue above the gum line area. So that's very good. All right, different types of knurling. I grew up with D, that's okay. The first ones were E, then in the 70s, we had D. Then we came out with C, which ended up falling apart in the ultrasonic. Then B came along, just a different material. And now you're dealing with the A's. And even now, next year, they might even have, the students might have different handles because Hugh Freedy came out with a even more advanced ergonomic design. So they're always reinventing themselves for the sake of us and our protection. So working end, single end, double end paired, double end unpaired. What is an example in your kit of a double end and unpaired? Can you think of one?
Explorer.
Yes, your 1723 Explorer, but your ODU Explorer is a double end and paired. They are mirror images, and a single ended would be your mouth mirror or your probe. Parts of a curette blade, you want to know, again, as a review, where the face is, and what meets the face is the lateral surface and the back of the blade. And then you've got your toe or your tip. Is it triangular in cross section, or is it semicircle in cross section? Your grasp, you've got your dominant hand, whether you're right-handed or left-handed. You have your non-dominant hand, which is what you'd be using your mirror for. Then there are different types of grasps. The palm grasp, modified pen grasp are your two primary grasps that you'll be doing, and we want to maintain a neutral wrist position. So this is called a port polisher. And when COVID came out and nobody was allowed to polish, the social media hygiene sites were really making fun of those who were bringing out their port polishers from their hygiene kits. We did not have this in our kits, but we had them in the clinic. And I took one for my boards because our contingency plan was, if my handpiece didn't work to polish, what was I going to do? Well, you had to get the biofilm off and the stain off somehow. So that's where the port polisher came in. And this is a wooden wedge here, and it comes as a little edge. And then you pull up the prophy paste and you're literally scraping that prophy paste against the tooth. It works quite well. And guess what? It doesn't create any aerosols, but it's great for stain accumulation. And then we've got your modified pen grasp. So as a review for the final, as well, you need to know what the modified pen grasp is and the functions of each of the fingers. So I always like students to kind of keep this picture or something like it in their head when they're using their grasps on a patient or their partner, and just kind of freeze frame and stop and take a look at your hand. What does your hand look like? Does it look like this? If it doesn't, you need to kind of refocus. I mean, and why doesn't it? Do you need to change your seating position or something else, or the patient's position? We want to maintain neutral wrist position. We're getting more and more into that as repetitive injuries are becoming more prevalent. Wearing a proper fitting glove also is so important. If your glove is too tight, you're going to be crimping this carpal tunnel area. And you can end up with injuries just by wearing a too tight of a glove. I used to love small gloves because they fit my fingers. But what was going on with that was the palm was a little bit too tight, and my hand was continually trying to stretch to increase that palm diameter for me. So, excuse me, I've learned to deal with a little bit bulkier, larger fingers to get my palm to stay at rest. The fulcrum. Right now, you are using intraoral fulcrums only. At the beginning of DNH 244, we will demonstrate and explain the extraoral fulcrums. And you will be able to use extraoral fulcrums. Yay, in DNH 244. But until that time, we really need to know that you can have control of your instrument. With that extraoral fulcrum, there also are alternative fulcrums that we will teach you about. We're not going to be going into a lot of those because you'll have a seminar in DNH 244. So instrument adaptation is the top picture. Good or bad?
Bad.
Bad, right, because you can see that the tip is flying off the tooth, right? You want to make sure that you have the tip third or the toe third of any instrument in contact with the tooth surface at all times. Your adaptation and angulation. Please know the definitions of them. So for adaptation, okay, you want to make sure you're using the toe or tip third. Angulation for your working stroke, you want to go in with the face of the blade as close to the tooth surface as possible. You slide it down underneath the deposit. You open up that face to the proper angulation, and then you snap that calculus off, trying to break that off the tooth. So that is the classic working stroke. And then you relax, and then you pause, you go down underneath, you open, and you snap. Pause, go underneath, open, snap until you feel a smooth tooth surface. So it is a deliberate stroke. And that's hard to do when you're just pretending, isn't it? So your activation stroke is you are placing more pressure on your fulcrum. You are increasing your lateral pressure. You are always moving in the direction of the tip or the toe. You're not backing into anything. You're using a walking exploratory assessment stroke as you're underneath the tissue. Walk, 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 walk. When you feel calculus, that's when you do a calculus removing stroke. So you are debriding very lightly, medium length strokes, light pressure, very light pressure, and you're deplaquing, breaking up that bacteria on the root surfaces. And when you encounter calculus, that's when you close the blade, you go underneath that calculus, open the angle up, and snap that calculus off. Then you've got your root debridement or root debridement stroke, and that is a little bit lighter than the calculus removal stroke. Okay, it's kind of in between the feather light and the calculus removal stroke. You want to move that instrument in all directions to make sure that you are doing the entire root surface. Your fingers, when you're pivoting and rocking on your fulcrum, naturally go into an oblique direction, but you also want to do vertical directions. And when do you do, what are the surfaces that do the horizontal strokes the best? What does the book say horizontal strokes are good for?
Line angles.
Line angles. And the straight facial and the straight lingual, like this picture depicts. So if this is the buccal of a tooth and it looks like a two-rooted tooth, which tooth would this be? Was it be a first molar or a second molar?
Second.
Why?
Because of the groove, or I think it's the name.
Yeah, it's only got two cusps.
Yes.
Exactly. The first molar is going to have two buccal grooves. So let's look at your scalars. These are your green instruments, all right? Your internal angles, guess what? 70 to 80 degrees. If you ever have to guess at anything, it's 70 to 80 degrees, right? You see that a lot. So there's a reason for it, all right? Even the angulation of your blade to the tooth is 70 to 80 degrees, but it's triangular in cross section. It's got two blades. The C are the blades. Comes to a point. You have your sickle scalars and your jaquette scalars. These are made for supragingival calculus. They are not meant to be subgingival. They are not meant for root surface. Now, does that mean we never use them on root surface or subgingival? Heavens no, we do. If it works, you're going to use it, but that's not what they were originally designed for. When we first started cleaning teeth, so to speak, we didn't know that calculus was underneath the gum tissue. We didn't realize that the biofilm and the bacteria was always on top of the calculus, and that the subgingival calculus was an issue. So these were some of the first instruments designed to just scale supragingival calculus. I worked with a hygienist who was older than me, but this was a number of years ago, and they didn't even learn subgingival scaling when she was in school. It was just subgingival. So she had to teach herself how to do subgingival scaling. Posterior or anterior jaquette scalar, and the jaquette scalar is just more of the shape of the scalar itself. So your 204S, your posterior jaquette scalar, versus your anterior scalar is a sickle and a jaquette combined. Then we've got our curettes. Your curettes, look at this, the blade angulation, the internal angle is exactly the same, 70 to 80 degrees, as it is in your other scalars. All right, but it is got a curved back, which will show you that is meant for tissue protection. And instead of a point or a tip, it comes to a toe. Universal curettes are made to work in the anterior and posterior parts of the mouth. Your ODU Explorer is a universal explorer. We are only showing you how to work it in the posterior areas right now. Same way with your universal curettes, your Barnhart, your yellow instruments can be used in the anterior area as well. But that involves flipping the instrument from mesial to distal, and it just is confusing for novice students. So we're only showing you the posterior. When you are learning your extraoral fulcrums in 244, you will also be learning how to use these instruments in the anterior area. So we have universal curettes, area-specific curettes, which are your mesials and your distals and your anteriors and your posteriors, and then the advanced area-specific curettes. And the advanced area-specific curettes could be your mini, your micro mini, your after 5. They could be, instead of a mesial instrument and a distal instrument, it is a mesial on one end and a distal on another. So you don't have to change instruments when you're doing a sextant, for example. And then there is curette specific instrumentation. All right, so this angle is a 90 degree on picture A. Is that a universal or area specific?
Universal.
Universal. Versus B is an area specific. Again, you've got that 70 degrees instead of 90 degrees. It is the exact same instrument as far as the design of it and everything. All they've done was angle the face. Instead of 90, it's at 70 degrees. Different types of Gracie curettes. You have your standard Gracie curette. And you've got a 1-2, a standard 1-2 in your kit. It's got a pretty big face here. But you can tell, the thing I like about the standard is you can tell what the working end is easily. Okay, is it face, you know, is it the right working end? Versus an after 5, look at, it's the same instrument, but look at how much longer that shank is, that lower shank. You've got your mini 5, it's an after 5 curette with just a little face of the blade. And then you've got your micro mini, which is even smaller. So if you're having problems determining which is the working end on the mini, the micro mini is going to be even worse. So when we say we don't care which instrument you use, you want to also think about for the anterior, what is the surface you're trying to reach for? Is it a broad tooth like number 8 or 9, or is it a narrower tooth like 24 or 25 facial or lingual? What size do you need that face of the blade to be and that working end here? Because you don't want to be too small, or you could gouge a root surface, or you don't want it to be too large because you could then be harming the tissue subgingivally. Now there's something that we have in clinic. These were in my instrument kits. We stopped putting them in kits because you don't need them very often, but they're called periodontal files. You need to know what a file is, right? Because this is really great when you have heavy calculus that the ultrasonic scaler isn't going to be able to budge, or if your instruments are starting to bend, that shank will actually start, you can see it moving because it's too big and heavy of deposit. Or if you have that burnished calculus that's so smooth, your instrument can't bite into it. And that's one of the disadvantages of relying on an ultrasonic scaler. Ultrasonics tend to burnish calculus. They make it smooth. If it's smooth, your Explorer is not going to detect it well. If it's smooth and you can't detect it, you're not going to get good tissue resolution because you're never going to get attachment there. So they have something called working files and finishing files. And think about when you're filing your nails or filing a piece of wood or something. You've got thicker, heavier stuff that's going to scratch but really clean well, but you don't want to leave those scratches. So then you need to buff a little bit with the finishing files. And the same thing with prophy paste. If you have to use a coarse prophy paste, you always follow up with a fine prophy paste. You don't want to leave those scratches on the enamel or on the root surface. So you want to buff and make things smooth. So that's the difference between the working and the finishing. All right, and this is what a file looks like. It's got steps. Each one of these is a blade. Each one of these is a blade. And what they do is it crushes the calculus. It's flat. So this part goes against the tissue. This part goes against the calculus, and then you're placing pressure against that calculus, usually with your non-dominant hand. It's against the gum tissue, and you're trying to crush that calculus, and you pull up because you don't want to push things down. So you're pulling it up. And what that does is it chunks up that calculus. So then when you go in with your ultrasonic or your hand instruments, it's more of a manageable situation. But this is beautiful for burnished calculus. In fact, I got a phone call from Ms. O'Brien today going, "Where are your files?" Because I was recommending files to a student. Use today. So anyway, we've got them in clinic. These are for heavy, heavy patients. This is a diamond coated file. And oh my God, I loved these when they first came out. Where would this be a good place to use this particular file?
Furcation because of the curve.
I'm sorry, Jonathan, I couldn't hear you.
Since it's curved, would it be like furcation areas?
It would be exactly the furcation area. Yes. diamond coated, and I used it all the time. But guess what, folks? This removes cementum like crazy. I was overusing it this about 12 years ago. It was like, oh, this is the best thing since sliced bread. And I was using it on every crotch of every furcation I could find because I wanted it to be as clean as possible. Well, I don't know if I was doing the patient any good or not. So I've really had to hold back on my eagerness for that. But that's a hand instrument. They also make these diamond coated ultrasonic instruments too. So you talk about being able to cause a little bit of root damage. Oy. So speaking of ultrasonics, there's something called powered instruments. We have put this off until next semester because of some of our other restrictions. It is a very much an aerosol producing device, but there are mechanical vibrations, and the vibration actually smacks against the tooth somehow, and that is going to break off the calculus. So the machine that by vibration is doing some of the work and not your hands doing all of the work. So this is great for medium to large pieces of calculus. It's even, depending on the tip, you can use it on slight calculus. It's great because it's a water lavaging device. You can flush out bacteria and just soft debris from underneath the gum tissues. So we come to be using this a lot until COVID. So the nice things with how you are going through the program is you are really going to know how to use your hand instruments. When I was a student, we only were allowed to use ultrasonic scalars on very certain patients, and we had to check it out. Now we're using it to even deplaque. But there are some contraindications for these. You can't use powered instruments on everybody. Systemic health conditions, what do you think might be one of those contraindications?
Patients with the COPD.
I'm sorry, patients with what?
With the lung issue, like lung problems.
Lung problems, exactly. You've got the patient laying back, you've got water in their mouth, you've got all these aerosols being produced. You don't want them inhaling the bacteria that you're loosening up. And guess what? You don't want to be inhaling it either. So, systemic health conditions for the patient, absolutely. Oral and the other systemic health condition, it's not so much anymore, but we used to not be able to use these instruments with patients with pacemakers because of the magno-restrictive issues with the pacemaker. Now everything is sheathed and it's okay, but we still need to get a medical clearance for these pacemakers, which we've discussed in the past. So if they're immunocompromised, also you want to be careful with what type of bacteria you are going to be dislodging and what they are going to be inhaling. Oral contradictions, anybody have a guess for oral contradictions? Again, it would be somebody who has a lot of bacteria that you don't want to necessarily aerosolize. So oral conditions, you might not want somebody with hepatitis or some infectious disease, virus or whatever, to be in the chair where you're using ultrasonics. All right, same thing with COVID. We don't want those aerosols no matter what. Oral conditions, if they have a lot of tooth decay, decalcification along the gum line area where you might accidentally, not purposefully, go into the tooth structure itself because you can't see. Other oral conditions would be removing, trying to remove a lot of biofilm or stain with the ultrasonic without knowing what the condition of that tooth is underneath, because a lot of times there is decalcification underneath that stain or biofilm that's there. So patients might also be very sensitive to the vibrations, to the temperature of the water, to the suction. If they're really sensitive, just the high-speed suction, that cold air can drive them nuts. So we want to think about what we're recommending for what patients, okay? And what are the risks and what are the benefits for these patients? So we've got sonic and ultrasonic technology. We use ultrasonic now. Sonic has been around for years and years and years and years. It goes on the handpiece, just like your Profi angle. It is air driven, right? And it makes one of the most awful noises. Everybody could tell when somebody was using that sonic. It was horrible. But look at the movements, 2,500 to 7,000, okay, movements per second. Okay, it's an elliptical motion and all sides are active. So it is a powered instrument. It doesn't need to have water coming out of it. It is just a jackhammer, if you want to look at it that way. And then we've got our ultrasonic technology, and there's two types of ultrasonic technologies out there. There's magno-restrictive and piezoelectric. They are both considered ultrasonic. Now at Nova, we have the magno-restrictive. That's what you hear as Cavitron. Cavitron is a name brand of a dense ply Sirona unit, okay, but it's a magno-restrictive ultrasonic. Piezoelectric, Hugh Freedy, a lot of companies, Acteon, make piezoelectric. Piezo is not in the United States the most popular. It's still magno-restrictive. In Europe and other countries, the piezoelectric is the most popular. So they work a little bit differently, but look how fast those movements are. 18,000 to 45,000 cycles per second. Okay, piezo, 25,000 to 50,000 cycles per second. Fast. Magno-restrictive is elliptical versus linear is the piezo. For the magno-restrictive, you have all sides that are active, the face, the back, both lateral sides, versus the piezoelectric, only the lateral sides are active. So for the piezo, it's a little more technique sensitive. Does that make sense? Because you have to use the sides of the instrument. Cycles per second. Sonic scalars are out there. Again, I'm not going to harp on these. I have not seen any board questions about sonic scalars, so I'm not going to delve into them. Just kind of browse the book to know that it's a lower powered instrument versus the magno-restrictive. The mechanism of action are these magno-restrictive stacks. There's all of these stacks here, and that's why you have a cassette just for your ultrasonic handpieces. Okay, and we'll get into that next semester. So you've got these stacks, which creates the vibration. You have an O-ring. This is the handle grip where your fingers go. Okay, then you've got your tip and a point, depending on the style of insert that you have. There's 25,000 and there's 30,000. Okay, we now have the 30K inserts. The mechanism of action, again, for the magno-restrictive is these stacks. And it's an elliptical motion of the tip, elliptical. It goes kind of in a circle, right? Versus the piezo electric ultrasonic scalar, you have crystals that are going to create the action. And the movement is linear. With these power instruments, they all have different sizes and shapes of the tip or the insert that you need, depending on where you're trying to go. Is it a lot of calculus, heavy calculus? You're going to need a thicker instrument versus a thinner instrument. What bends are on them? The curves, those type of things. What access do you have? So they can be very site specific. The power setting. On our units, we've got new units as of a couple years ago, and it is percentage. What's the power percentage? 20%, 30%, 50%, 100%. All right, but they have low to medium, which is 50% or lower, and medium to high, which is above 50%. You have to match the power setting to the insert that you have. Magno-restrictive and piezoelectric technology requires water because that energy is producing heat. That heat will heat up the tooth and you can cause pulpal damage. So the water acts as a coolant and also acts as a lavage for underneath the gum tissue. So it can help flush out underneath the gums. So these are different ultrasonic tips. And the piezoelectric they've got so many tips, it's just mind-blowing. But this is what I grew up with. This is a universal design. This is about all we had way back when. Okay, and it's pretty thick versus this is what we call a triple bend. You can see that it's got some angles to it and it's thicker. So which would be for the heavier calculus? It would be this triple bend, would be for heavier calculus. Then back in the early 80s, there was a Dr. Holbrook that came out with the idea that you could do subgingival root planing, root debridement with an ultrasonic much more efficiently and thoroughly than you can with your hand instruments. But you needed to customize the tips. So we would all take these tips into the lab on our lunch hour and we would hone them down, make them into thin tips, kind of like a probe tip, and reset our ultrasonic to the proper settings for that, because this would get places that your instrument, your hand instruments just could not reach. Then the instrument industry said, well, if everybody's honing these guys, let's make these guys, and this is where your slim lines come in. And those are your green ultrasonics. We haven't brought them out yet, but you've got a universal, and then you have your left and your right. You've got them with big curves on them, kind of like your neighbor's probe. This is called a beaver tail. And it's got a nice flat edge. This is great for ledges of supragingival calculus and heavy, heavy stain on the anterior linguals. It's great for that. We have a couple of these in clinic. So if you ever have a patient that you think you want to try one on, get your instructor and we'll try and find it for you. Now for the grasp of a powered instrument, guess what? You can use finger movement with these because it, again, is the machine is doing the work and not your hands. So you want a light grasp, okay? And you want the machine to do the work. Now, I don't know if you come up with having problems with sore hands or your muscles are cramping or your thumb hurts or whatever after a day in clinic. But there are dexterity exercises that you can use, and I'm not going to go over these. But if you need to strengthen, you can. What I like about the rubber band here is that you can take your index finger and separate it from the rest. Then you take your middle finger and separate it. Then you take your ring finger and separate it. There are pencil exercises. I'm not going into these. Just know that if you have issues with them, with your hands, there are pinpointed exercises that you can do. And your Gehrig textbook has these as well. We want to avoid cumulative trauma. And think about what we do every day, ladies and gentlemen. We have our hand in almost the same posture all the time. So it's important that we kind of change things up a little bit. So sometimes we're standing, sometimes we're sitting, sometimes we're altering the routine on what we do. I like polishing first, for example. Now, you know, when you're in school, oh my God, you what? Well, if I'm disclosing somebody, I want to, after I do TBI, toothbrush instruction, and OHI, especially on a child, I'm going to polish first, because I can't tell you how many times I've thought I got all the calculus off, and that was biofilm. I polished the biofilm off. Guess what? There's calculus underneath there, and you have to go in and rescale it. So anyway, you'll develop your own habits, and whatever you do, we want you to protect your body at all times. So you are fortunate to learn how to sit properly on a saddle. And by the time you graduate, you might even want to purchase your own saddle with student discounts. And that is your saddle. You don't depend on your employer to take care of you. If you really want to take care of yourself, get your own saddle. You'll get your loops and your light. You'll get what you need for you. Some hygienists have even purchased their own ultrasonic units, especially if you do a lot of temping and you're going from office to office. That way you know you have what you need to treat those patients well. When you are going to the sterilization area with your instruments, please make sure that your cassettes are locked at all times. They need to be closed and locked. You're not bringing them opened in case you bump into somebody. We want them closed at all times. Ideally, they are in a closed container while you're carting them. That rarely happens. University of Maryland, they do that, but we don't. Just make sure that they're closed. You've got your heavy duty gloves on. You're using all of your instruments now. So hopefully you're using the ultrasonic scalar, or I'm sorry, the ultrasonic cleaner. Okay. And if you're keeping your instruments wiped, if you don't know what the Nova wipe is, that's where your gauze is on the tray. And then you're using your mirror to take the gauze over and wipe your instrument. You're not using your fingers for this with the gauze on it. But if your instruments are wiped and clean, it's going to really help that ultrasonic cleaner, and you'll always have clean instruments. When you start using a lot of polishing paste and disclosing solution on a lot of your patients, which you will next semester, take a look at that mirror every now and then, because where the mirror head is and where the mirror face is, oftentimes that gets gunked up and you need to take and explore and kind of clean around it. It's very embarrassing for, say, me to sit down and I'm doing an oral inspection. You've already done the oral inspection, the EOIO. I'm sitting down, or your instructor's sitting down to redo it, to sign you off on that skill. And we pick up the mirror and we're seeing all this dried gunk. You know, it's already been in the patient's mouth. My daughter claims that I'm lopsided, because I am always bent over with my left shoulder down a little bit, because guess what? For 40 years, that's how I've been working. So I'm just kind of like that. And at this point, I don't know if I will ever be able to correct my posture. Documentation is especially for if the patient's dentition requires more careful attention. Think about those mandibular anteriors, and if they're tilted lingually, how are you going to do those linguals? They can be a pain in the neck to get. That really strong lip or tongue that's always pushing you out of the way. your non-dominant hand sometimes isn't even strong enough to keep that lip from covering up those teeth. So those little cheat notes can help. We always want to explain to the patient what we're doing and why, especially when we're using different instruments like the powered instruments, the ultrasonic instrument, and they've never had it done before. Well, gee, Susie's never done that, and I've been coming every 3 weeks or every 3 months for Susie for years. Why are you deciding to use that? Well, you know, why? You need to explain it to the patient in terms that they can understand, and without making Susie appear that she's been neglectful in any way. And that can be a thin line, especially if Susie is not the greatest scaler. She might have been the best chatter and connecting with the patients, but her scaling techniques might not have been great. And you're dealing with all of this residual calculus. How do you approach that with your patient? Susie's still there. We'll be getting into those type of situations later though. Okay, any questions on periodontal instrumentation? I'm taking that as a no. Okay. What time is it? I don't even know what time it is. All right, it's been almost an hour. Why don't we take just a 5-minute break and we'll come back. Is that okay?
Yes.
Yes. Hello. Okay, we'll take a 5-minute break, guys, and then we will move on. Thanks.